It's time for another warm-up review. Let's get going. First question here, which bacteria secrete enterotoxins? So first we have Vibrio cholera. We also have enterotoxigenic E. coli. So that's making a heat labile toxin that causes similar diarrhea to cholera. Staph aureus has a series of enterotoxins. Shigella, Yersinia, Clostridium species, specifically Clostridium difficile, and also Clostridium perfringens. Next, what is Charcot's neurological triad? So Charcot's triad is associated with multiple sclerosis, and it consists of scanning speech, intention tremor, and nystagmus. Next, what causes subacute endocarditis? So we have viridin streptococci, we have enterococci, and then sometimes coagulase negative staph, specifically staph epidermidis. All right, that's it for the review. Let's get to the video.
In this video, we're going to talk about diuretics. But first, you want to hear a nephrology joke? Well, you're in luck. Get it? You're in luck? Anyway, the other day I found Dr. Lewis just staring intently at this can of orange juice for like hours and hours and hours. And I asked him, "What are you doing?" He said, "Well, the label on the can says concentrate." On that note, let's concentrate on diuretics. You need to be able to identify different drugs based on what type of diuretic it is. And you need to know the mechanism of action of each one and exactly where in the nephron the different classes of diuretics work. So we're going to group the diuretics by their sites of action within the nephron, from proximal to distal. So the most proximal part of the nephron is the proximal convoluted tubule. And the diuretic that works here is acetazolamide. So acetazolamide is a carbonic anhydrase inhibitor. Remember, carbonic anhydrase in the lumen of the proximal tubule converts bicarb to CO2 and water, which could be reabsorbed. And if you inhibit carbonic anhydrase, you can't reabsorb bicarb, so you excrete it in the urine. So acetazolamide does have a minor diuretic effect, but we mainly use it not for its diuretic properties, but to facilitate the excretion of bicarbonate. So when would you want to excrete bicarbonate? Well, one condition is altitude sickness. Think back to the pulmonary video on high altitude medicine. If you're at high altitude, the partial pressure of oxygen is lower, so you have to breathe faster and deeper in order to oxygenate the body. So you're increasing ventilation. Now when you increase ventilation, you're blowing off more CO2, and that leads to respiratory alkalosis. So eventually, over time, your body's going to compensate for that respiratory alkalosis by getting rid of bicarbonate. But that can take several days. So if you have a patient with altitude sickness, you can give acetazolamide to help them excrete bicarbonate and overcome this respiratory alkalosis much more quickly. We can also use acetazolamide to alkalinize the urine, because all that bicarb in the urine makes the urine more alkaline. Or we could use it to treat metabolic alkalosis and help the body get rid of bicarb that it needs to get rid of. We also use acetazolamide to treat glaucoma, because bicarb production draws water into the eye to form aqueous humor. So blocking bicarb production reduces production of aqueous humor. That's going to reduce the intraocular pressure. And acetazolamide is the first-line treatment for idiopathic intracranial hypertension, or pseudotumor cerebri, because it reduces the production of CSF as well. Then for the side effects, acetazolamide can cause metabolic acidosis. Even if you're using acetazolamide eye drops for glaucoma, it can still cause metabolic acidosis. You're losing bicarb in the urine, you're becoming acidotic. Then it's also a sulfa drug, so it can lead to sulfa allergy. So if you have a patient with a sulfa allergy, you don't want to give them acetazolamide. Now, lots of different diuretics are sulfa drugs, so you're going to need to pay attention to that. Next up is mannitol, which also works in the proximal convoluted tubule. Mannitol is an osmotic diuretic. Mannitol causes an osmolar load that stays in the filtrate and prevents reabsorption of free water in the proximal tubule. So it causes excretion of free water. Now obviously mannitol will raise serum osmolarity, but what does mannitol do to the serum sodium? Well, if you're losing free water, serum sodium is going to rise a little bit. Now in terms of side effects, mannitol can cause dehydration because you're losing a lot of free water, and it's contraindicated in patients with anuric renal failure patients who don't make any urine. It's also contraindicated in patients who have congestive heart failure. Now we don't use mannitol very often. Occasionally you'll see it used to treat shock or drug overdose. Sometimes we use it to lower intraocular pressure in patients with acute angle closure glaucoma. You wouldn't want to treat chronic open-angle glaucoma with mannitol, but you might give IV mannitol for acute angle closure glaucoma. So remember, there are two diuretics that can be used to treat glaucoma, acetazolamide and mannitol. And sometimes we use mannitol to treat elevated intracranial pressure. not really because of its actions in the kidneys, but because of its actions elsewhere. So you give IV mannitol, and it goes into the circulation, and it draws interstitial fluid into the vasculature to balance that intravascular osmolar load. So fluid's going to shift out of the swollen brain and into the vasculature in a patient with elevated intracranial pressure. The next group of drugs is the loop diuretics, which includes bumetanide, ethacrenic acid, furosemide, and torsemide. Now, of these four, furosemide is the most commonly used one. The brand name for furosemide is Lasix. And you should know that furosemide, bumetanide, and torsemide are all sulfonamides, so you can't give these to patients with sulfa allergies. But ethacrenic acid is not a sulfonamide, so it's the one loop diuretic that's safe in patients who have sulfa allergies. Now, what part of the loop of Henle do we say that the loop diuretics work in? Well, in the thick ascending limb. So loop diuretics inhibit the sodium chloride potassium cotransporter. And if you can't actively pump those electrolytes out of the filtrate into the interstitium of the medulla of the kidney won't be so hypertonic, which means that back in the thin descending limb, you won't be able to concentrate the urine. So even though loop diuretics increase the amount of sodium and potassium and chloride in the urine, they also promote a more dilute urine because the urine volume is just so high. And loops also increase calcium excretion. So loops lose calcium. Loops lose calcium, and thiazides retain calcium. I want you to remember that entire phrase. Loops lose calcium, thiazides retain calcium. So if you have a patient with hypercalcemia and you want to lower the serum calcium, you could reach for a loop diuretic. And if you want to retain calcium, you could reach for a thiazide. So when do we use loop diuretics? Well, they're used mainly in patients with serious edema, CHF, pulmonary edema, nephrotic syndrome, cirrhosis, things where you have a lot of fluid that you need to get rid of relatively quickly. You might use a loop diuretic. The loop diuretics are the most potent diuretics that we have. Now, loops are not commonly used for hypertension. They do reduce blood volume, they do reduce the blood pressure some, but it's much more common to treat hypertension with a thiazide diuretic than with a loop diuretic. Then for the side effects of loop diuretics, the most common side effect is probably hypokalemia. Patients taking loop diuretics chronically are going to excrete a lot of potassium, and they can potentially become hypokalemic. We often have to give these patients potassium supplements. And obviously when you're losing a lot of fluid, you can become dehydrated. Loops can precipitate gout because they interfere with uric acid excretion. We already mentioned the possibility of a sulfa allergy, except for which one? What's the loop that's not associated with a sulfa allergy? Ethacrenic acid. It's the only one that's not a sulfa drug. So if you have a patient who needs a loop diuretic but is allergic to sulfa drugs, you could use ethacrenic acid. That's really about the only time we use ethacrenic acid. And it's pretty rare, but loop diuretics may cause ototoxicity and nephrotoxicity, similar to the aminoglycosides and also to vancomycin. So if you give a loop diuretic plus an aminoglycoside, you could really increase the risk of ototoxicity and nephrotoxicity. Making our way through the nephron, we're going to leave the loop of Henle and arrive in the distal convoluted tubule, which is the site of action of the thiazide diuretics. Now, thiazides are probably the second most potent class of diuretics. There are a ton of different thiazides, but the ones that actually get used most often, therefore the ones you're most likely to see on your test, are chlorthalidone, hydrochlorothiazide, which we often abbreviate HCTZ, and metolazone. And hydrochlorothiazide, or HCTZ, is probably the most commonly used one of all of these. Now, thiazides work by inhibiting reabsorption of sodium and chloride in the distal convoluted tubule, so they reduce the diluting capacity of the nephron. This means you're losing a relatively high electrolyte fluid in the urine. And as I mentioned, thiazides retain calcium, so they decrease calcium excretion. And you're going to have less calcium in the urine, and therefore more calcium in the serum. And this can be useful if you have a patient who's at high risk of developing osteoporosis. They have some hypertension as well. You could start a thiazide, which is going to lower the blood pressure. It may also help prevent osteoporosis because it prevents calcium excretion. It may raise the serum calcium slightly. But the main clinical use of thiazides is to treat hypertension, as we mentioned back in the cardiovascular section. Remember, thiazides are one of 4 classes of drugs that are used first line to treat hypertension for most patients. Remember, those 4 classes of drugs were the thiazides, the ACE inhibitors, the ARBs, and the calcium channel blockers. Now, on the other hand, it's much less common to use thiazides for CHF or other edematous diseases. We're usually going to use more potent diuretics for those, like a loop diuretic. Now, you might use thiazides for idiopathic hypercalciuria. So if you have a patient that has normal serum calcium, but who dumps a lot of calcium in the urine, that's going to cause calcium stones. So a thiazide might help prevent this because it's going to prevent some of that calcium from going into the urine. But if you have elevated serum calcium, maybe from hyperparathyroidism, and that's causing you to spill calcium in the urine, then you don't want to use a thiazide in those patients because the thiazide is only to make the hypercalcemia worse. So you don't give a thiazide to a patient with hypercalcemia. But if the patient has idiopathic hypercalciuria, you can give a thiazide to prevent those calcium kidney stones. And thiazides are also used to treat nephrogenic diabetes insipidus. We're going to talk about that in the next video. Then for side effects, thiazides can cause hypokalemia, just like the loop diuretics can. That's very important. They can also cause hyponatremia, hyperglycemia, hyperlipidemia, hyperuricemia, and hypercalcemia. Remember we said loops lose calcium, thiazides retain calcium. And thiazides are also sulfa drugs, so you're going to want to avoid these in patients with sulfa allergies. Our last group of diuretics are the potassium-sparing diuretics, which we said work in the collecting tubules primarily. Remember, all potassium-sparing diuretics are not created equal. The common feature is that they all spare potassium. Instead of promoting potassium excretion like the loops and the thiazides do, the potassium-sparing diuretics reduce potassium excretion. They help potassium stick around. So one way to remember which diuretics are potassium-sparing diuretics is the phrase, take a seat. You capitalize the K in take because that's the chemical symbol for potassium, and you're saying take a seat because you want the potassium to stay put. Then the letters SEAT stand for spironolactone, eplerenone, amiloride, and triamterene. But the reason we say they're not all created equal is that spironolactone and eplerenone are aldosterone antagonists. And then amiloride and triamterene work by blocking sodium channels, but they don't antagonize aldosterone. They work a little bit differently. So if you had a patient with hyperaldosteronism, you could treat with spironolactone or eplerenone. Think about it. Aldosterone causes retention of sodium and loss of potassium, so an aldosterone antagonist will counteract this. We sometimes give a potassium-sparing diuretic, especially triamterene, concurrently with a loop diuretic or a thiazide diuretic. So say you have a patient with CHF and you're starting furosemide and the patient starts to get hypokalemic. Well, you might give a potassium-sparing diuretic along with the loop diuretic in order to retain some potassium and prevent that hypokalemia. And then in CHF, remember that the aldosterone antagonists have been shown to reduce morbidity and mortality in these patients with heart failure. So we can use these in low doses in patients with CHF. We said that the patient with CHF needs to be on several different drugs. They need to be on a specific beta blocker, they need to be on an ACE inhibitor or an ARB, and they need to be on one of these aldosterone antagonists. So those are the drugs that have been proven to increase survival and reduce mortality in CHF patients. And then if that patient's having fluid retention, they most likely need to be on a stronger diuretic as well. Now, what about the side effects of the potassium-sparing diuretics? Well, obviously, retention of potassium could lead to hyperkalemia, and that can lead in turn to arrhythmias like VTAC or VFib. You should also know that spironolactone is very structurally similar to sex hormones, and it can antagonize androgen receptors and cause gynecomastia in men. So you remember the mnemonic STACKed for the drugs that cause gynecomastia? Well, the S was for spironolactone. Now, occasionally we use these anti-androgen effects therapeutically. So we might give spironolactone to treat acne or to treat polycystic ovarian syndrome or PCOS. Now, spironolactone also has progesterone agonist activity, and that can cause some menstrual irregularities in women. And it's worth noting that eplerenone is more specific for the mineralocorticoid receptor. It doesn't really bind to the androgen receptors. So you're not going to get anti-androgen effects with eplerenone the way you do with spironolactone. All right, now let's go ahead and do a quick whiteboard review. For this review, we're going to sort all these different diuretics into the correct classes based on where in the nephron they work. We're going to start in the most distal nephron just to switch things up. So out in the collecting duct or the collecting tubule, you have the potassium-sparing diuretics. The mnemonic we had was take a seat. So the S is for spironolactone, the E is for eplerenone, the A is for amiloride, and then the T is triamterene. So those are your potassium-sparing diuretics. Then working back up the nephron, we have the distal convoluted tubule. And what works there? The thiazides. So the three thiazides we talked about were chlorothalidone, hydrochlorothiazide, that one's pretty easy to recognize, and metolazone. Then going back to the thick ascending limb and the ascending loop of Henle, those of course are the loop diuretics. The loop diuretics are bumetanide, ethacrynic acid, furosemide, and torsemide. And then what do we say was special or unique or different about ethacrinic acid? It's the only one of these that's not a sulfa drug. And then we're back to the proximal convoluted tubule. In the proximal convoluted tubule, we have two different types of diuretics that work here. We have the carbonic anhydrase inhibitors, and we have the osmotic diuretics. So which one is which? Well, the carbonic anhydrase inhibitor is acetazolamide, and then the osmotic diuretic is mannitol. Now, let's go ahead and circle all the different diuretics that are sulfa drugs. So our sulfa drugs include acetazolamide, 3 of our 4 loop diuretics, and then all of the thiazides are sulfa drugs. So for your reward, we're going to put Dr. Lewis in a little roller coaster, because that's what the nephron always looks like to me. And he's just getting ready to go down this big, crazy hill. And this roller coaster is called the Renal Screamer. Like a nice, scary name. And unfortunately, Dr. Lewis tends to get a little bit motion sick. Before we wrap up, I want to briefly review some of the electrolyte and pH changes associated with these various diuretics. So virtually all diuretics will increase urinary sodium chloride, with the exception of acetazolamide. All of them are going to increase urinary potassium, except for the potassium-sparing diuretics. And you can get hypokalemia as a result of most of these other diuretics. And then for acid-base balance, we discussed how carbonic anhydrase inhibitors will cause some metabolic acidosis. You can also get some acidosis with the potassium-sparing diuretics. But with the loops and the thiazides, as you lose lots of sodium chloride in the urine, you're becoming slightly hypochloremic. And that hypochloremia results in reduced excretion of bicarb. When there's more bicarb in the serum, that's alkalosis. This is sometimes mistakenly called contraction alkalosis, as in the patient becomes volume contracted from using a lot of diuretics, or they become volume contracted from prolonged vomiting. But the truth is, it's probably hypochloremia that's driving the alkalosis. All right, so that's it for the diuretics. Now it's time for the end of session quiz. So go ahead and answer those, and then we'll go through the answers. All right, first question. What type of diuretic is each of the following drugs? So again, it's not enough to simply recognize these drugs as diuretics. You need to know what kind of diuretic each one is. So triamterene is a potassium-sparing diuretic. Acetazolamide is a carbonic anhydrase inhibitor. Hydrochlorothiazide, it's pretty easy, it's a thiazide diuretic. Bumetanide is a loop diuretic. Spironolactone is a potassium-sparing diuretic, more specifically an aldosterone antagonist. Ethacrinic acid is a loop diuretic, and specifically it's the one that's not a sulfa drug. Mannitol is an osmotic diuretic. Metolazone is a thiazide diuretic. Chlorothalidone is a thiazide diuretic. Furosemide is a loop diuretic. Amiloride is a potassium-sparing diuretic. And torsemide is a loop diuretic. Next, what diuretic or class of diuretic would be most useful in each of the following situations? So for acute pulmonary edema, remember we said that for heart failure, which is where you're classically going to have acute pulmonary edema, we have the mnemonic no lip, and the L in that no lip was for loop diuretics. The next bullet says idiopathic hypercalciuria resulting in calcium stones. This is where you might want to give a thiazide to reduce renal calcium excretion. So again, loops lose calcium, thiazides retain calcium. Glaucoma, we said the two diuretics that are occasionally used to treat glaucoma are acetazolamide and mannitol. Mild to moderate CHF with expanded extracellular volume. So if this is really mild, you might use a thiazide, but classically with heart failure patients, you're going to use a loop diuretic. In conjunction with loops or thiazide diuretics to retain potassium, that would be any of the potassium-sparing diuretics. Edema associated with nephrotic syndrome, usually you're going to reach for a loop diuretic. Increased intracranial pressure, you're going to go for mannitol again, not for its diuretic action, but to act as an osmolar load that's going to draw that fluid out of the brain interstitium. Mild to moderate hypertension, if you're going to use a diuretic to treat hypertension, it's generally going to be a thiazide diuretic. Hypercalcemia, you're going to reach for a loop diuretic to lose the calcium. For altitude sickness, you're going to use acetazolamide. And for hyperaldosteronism, you'd use spironolactone or eplerenone because, again, those directly antagonize the aldosterone receptors. Next, what's the site of action of the thiazides? So they work in the distal convoluted tubule. And the last question, a patient with heart failure exacerbation needs a diuretic but has a sulfa allergy. So what diuretic can you use? Well, again, loop diuretics and thiazide diuretics are both sulfa drugs. So ethacrynic acid is a loop diuretic we talked about with this one that's not a sulfa drug. All right, that's it for Renal 4. I'll see you next time.